So thank you very much, Anna, for the introduction and for giving us the opportunity to talk about ongoing developments in the field of blockchain for privacy. I must apologize. I'm not physically in person attending the meeting for traffic conditions this morning, so I could not get my flight on time and be there with you. I hopefully will be able to deliver my talk with the present internet connection. So my talk is about a project we are carrying out, which I believe is very well connected to AEGLE. So I shall start by introducing myself and my company so everyone understands. So I'm representing a company called Nubila that is part of the AEGLE consortium that has been working for more than 10 years in the field of biomedical research, developing products for anonymizing, basically de-identifying sensitive data for making it available for various clinical studies. And since about 2 years now, we've been acquired by a larger group in France, which is called Almeris, that you can see on the slide, which is responsible for trusted third payments for healthcare insurances and therefore handling the data of about 22 million people. So we are helping them with the GDPR related matters and in particular ensuring privacy by design. So my background is computer sciences. I did my PhD at CERN, at the European Organization for Nuclear Research, and I've been working into this field for now about 15 years. And so in participating to projects such as AEGLE, we've learned a number of lessons, in particular related to privacy and the compelling needs for protecting individuals' identities. And so over a time span of about 10 years, we've been contributing to about 20 international projects requiring sensitive data to be made available cross-enterprise and transnationally. And we did that for a number of different pathologies, clinical studies, or thematics, which needed to accumulate data so to statistically be able to validate different models for new decision support systems. AEGLE is a typical and very interesting example of such a case where you have lots of data coming from different centers that are needed to be put together, so they need to be harmonized, they need to be identified so that they can be further processed. And from our involvement in various studies of the likes, we've come to the conclusion that healthcare data is actually complex. It's very heterogeneous. Most of the time it's locked into proprietary solutions at the hospital's information system department, and it's very sensitive and personal. So to get the data out and make it usable for research purposes, you need to ensure security and privacy of individuals. And even more important to this, you need to develop trust with the participating centers, the ethics boards, the information system departments, and the physicians, so that they accept and connect to this network to share information. So we've come to a number of conclusions and started wondering whether we could generalize the principles we had tried to address in those various collaborations, so to liberate data. And one of the conclusions is that for us, what is really necessary is to have full traceability over the data that's been made available for various purposes. And so far we have developed solutions for de-identifying, for sharing in a distributed setting, but we had not taken aboard all of the traceability related matters. And Actually, 2 years ago, GDPR started taking shape. So dedicated expert group were working on the actual definition of GDPR and introduced progressively the concept of privacy by design and, more importantly, informational self-determination. So in the GDPR law, the rule that's going to be applied from 25th of May this year on throughout the entire European Union, these are the two major cornerstone of this new approach to making data available for various processing purposes. The first is that you have to make sure that data is protected and the actual identities of people are hidden in such a way that they cannot be re-identified when data is made available for processing purposes. And the second implies that you give some forms of control back to the individuals on their data, and amongst which the most famous, the right to be forgotten. So you have to have new generations information systems that are able to document, trace the provenance of data from the various information systems, and you have to make sure that individuals can access, modify, ask for deletion, or even to be forgotten from the system. So there are a number of rights that are coming up and that are now ruling the way personal sensitive data can be made available for processing purposes. And that's where we started with the My Health, My Data project. So we've come up with the idea that it should be possible to develop a network of good practices and make it possible for various types of stakeholders in the value chain to make data available and to abide to the GDPR rules in a transparent manner. So we've come up with a core model. It's actually a crypto model that is enabling this full traceability. And we've decided to develop a distributed ledger that would guarantee the full provenance traceability of data transactions in networks of heterogeneous stakeholders. And so we've developed a model that combines pre-cryptographic techniques to make it, to satisfy basically two orthogonal requirements. One being the intervenability, which is to make it possible for an individual to apply their rights at a given point in time on their data, but at the same time to ensure unlinkability for outside accesses or malicious accesses to the data. And so we've introduced a model that allows documenting data transaction that is made of an existence proof, that is a cryptographic hash of the data and its accompanying consent, a matching proof that makes it possible to document how and where an electronic health records was used in a given cohort of interest, and a membership proof that makes the whole system anonymous, where the stakeholders are protected in terms of their identity, be it the data provider, the data user, or even the actual servers signing the transactions. And we've basically developed a blockchain system that ties all of the stakeholders together along the value chain. What you see on the screen is the actual core model of My Health, My Data. On the left is this distributed ledger principles. So we are developing and maintaining a full ledger of data transactions that is entirely anonymous, that is made available publicly, that everyone can read, but that maintains anonymity for participants. And on the right, we are developing a valuation transaction mechanism that helps us making some economical value and societal impact assessment over the shared data. So we are creating a cryptocurrency that helps trading actually the data and that is based on an efficient cost payment scheme that we've tuned for specifically the healthcare sector. So we are developing an ERC20 standard token that is actually both a utility and security token that helps measuring, accounting for data being exchanged between various stakeholders, and at the same time economically evaluating the costs of these transactions. We are doing so with a particular technology. It's Hyperledger Fabric. It's actually one of the best known open source blockchain technologies available to date, and which is very close to industrialized standards. And that has a particular architecture that can fit very well the ecosystem, the healthcare ecosystem, in terms of its governance, because you can respect the actual authorities in place and have this blockchain fully mapped to the ecosystem. The model we are trying to develop is a socio-economical model for value-based care, where we have a double valuation, economical valuation of data transactions, such that we can make sure that participating centers that are collecting data, maintaining data, curating data, are economically incentivized, because this has a cost on their business model. And at the same time, we want to make sure we are able to measure the impact, the social impact assessment of having data available for various purposes. So we are working on a model based on open value accounting for doing so. And we are really lucky because with My Health, My Data, we have a European setting, so it's a European project funded under Horizon 2020 that allows us to develop a pilot at the European level. So we have a number of committed centers, actually hospital centers, that are sharing data and willing to host the solution. In our infrastructure, in the architectural principle we decided to develop, is that we are creating a blockchain of trusted parties. So we have a network of centers that are accredited, that are collecting data about patients, which agree at some point for research purposes to make their data available, provided of course they have an appropriate consent from the patient, to make the data available to a network of scientists. And so this is what we will be disclosing by June this year, the first version of this network. It's online accessible. It's also accessible from a regular mobile application that allows data owners and data users to register and browse through the actual offering from an online portal that distinguishes the various types of data that can be mobilized. The way it works is that centers are sustaining this blockchain environment in all data mobilization materialize as smart contracts. In other words, are as intelligent applications run on the blockchain. Depending on the type of user you are, whether you are an individual, a researcher, or a company looking to access data cohorts for validating your commercial application or validating your research principles, or even applying your GDPR rights, this materializes as a smart contract on the platform. The smart contract then goes down the various nodes of the system, the actual hospitals, and forward the formulated query from the graphical portal. And all the hospitals having data corresponding to the query respond, and the data is mobilized, is pulled on a particular type of node in our infrastructure. We apply a second level of pseudonymization, and data is delivered over the cloud. This is what we will be demonstrating. in June this year, on the 25th and 26th in Sofia at the European Commission's Digital Assembly. Basically, we will disclose the first version of this My Health, My Data network with the transactional platform so that you can, as researchers, access and mobilize data live from the system with dedicated smart contracts from 4 hospitals, and we'll have a sample of over 1 million electronic health records available for testing purposes. So this is what we are working on, the blockchain as a legal automation platform with the objective of accelerating science, so making data, dormant data available more quickly and easily to interested researchers. Thank you very much for your attention. Anna, you may have to repeat the questions close to the microphone because I will not hear.
Yes, okay. So, any questions?
Okay,
yes.
So is the data stored, the patient data stored in the blockchain or just linkages to the patient data?
Did you hear that?
No.
No. Is the data stored in the blockchain or they're just linkages to the data through the blockchain?
No, the data is stored in the participating centers, and that's the particularity of our model. The blockchain is just used as a distributed ledger and a transactional platform. We have developed this particular cryptographic model that enables full traceability, but anonymous traceability over the data transactions. And the centers that are participating are not only blockchain nodes, but also they are the trusted parties hosting their own data.
Yes.
So the technology, the distributed ledger technology, can it be deployed against basically any data store, or is it?
The distributed ledger technology can be used for any type of data stored anywhere?
Yes, yes, indeed. There are, in fact, what I didn't show all of the interfaces and the actual software architecture of our system, but there is an application called Driver that is installed at the hospital center, at the research lab, or whichever trusted party to become node of the network. In that driver application makes it possible to register it makes it possible to register structural data coming from research systems such as those that we used in AEGLE. In AEGLE we have a FEDER system that stores longitudinally all of the records made available for research purposes. But we can also expose directly files or archives of interest into the system, and there is no limitations of the types of information we make available. The model for tracing all of the data transactions is generic.
I'm wondering, from the presentation, it sounded like you were trying to monetize patient data because we're going to be paid for access. Is that right?
Are you trying to monetize patient data? Should people pay to access the data?
This is not exactly what we are trying to do. We are trying to do 2 things. We want to make it possible for hospital centers, for instance, to get some economical revenues from making the data available, but not on a patient basis. It's more on the actual cost of making the data available, so maintaining the databases and so on and so forth. So it will certainly be like an online registration with some sort of a freemium model. And at the same time, we would like to measure the impact of making data available. So we'll have a double valuation of the transactions. The point not being to monetize, strictly speaking, patient data. In the present version of the system, we are mainly talking about research data, so data made available for research purposes and therefore reusable for other types of research, but according to the GDPR definition. In the future, and as we have specialized partners in the consortium, we will be also testing the possibility for exposing personal data of various types and including social networks extracted data. We have a company called Digin in the consortium that has developed a connector from its application that extracts data from various types of networks, personal data, that makes it available to MHMD for other types of analysis.
Any other questions? One from Joanna.
Yes, I don't know if a small, which is not going to be a big one. So in AEGLE, we have a mapping from the local database to, let's say, central type scheme. Yes. They might help my data approach on, besides the blockchain, on the, let's say, data harmonization level. It follows the same approach for whatever database. There should be a mapping to a common scheme in order to work, or no?
Should there be a mapping from a local to a central database in the project, in the My Health My Data project, or is this something you're dealing with, merging and mapping from different local databases to a central one?
We are indeed handling this thanks to semantics. The driver application has a meta model, a mapping that we apply from the local data to a global schema with the associated ontological concepts. And the catalog that I briefly presented through a graphical user interface is actually making it possible to browse through the data according to ontological terms. So we abstract from the actual raw data and expose only counts and ontological terms to the data users.
So it's kind of automated.
Yes, it is, and we have additional to that a mechanism using SMPC, and so single multi-party computations. SMPC activated on the participating sites. And so if it comes to statistical queries that have to access the raw data, we can, from the portal, submit the statistical analysis to the various nodes through SMPC.
Thank you. One more question.
What is the ontology, or the source of the ontology?
What is the source of the ontology?
So we are using meshes and actually UMLS concepts.